So as Annie said, I'm going to take the first part of this talk, and then Clarissa will come in at the end, and we're going to kind of go through this somewhat chronologically through life. So I'm going to talk first about infants and babies, and then talk a little bit about young children, and we'll end with a discussion of kind of young adults in the U.S. and a group that she and I started at on Ward 86. So recognizing that most, if not all of you, haven't ever, and probably will never take care of children with HIV, I thought I'd try to keep this kind of as kind of concrete and interesting to you as I could. So starting with a case to kind of introduce each of the sections. But this will be a case that is a patient, but also kind of involving a provider. So I thought it'd be useful to imagine Annie, old friend and colleague and person that I work next to as doing this. So Annie, as you all know, Annie's very generous, and there was a call that came out because there was a hole in the perinatal hotline, or I should say the hotline kind of schedule. And Annie, she's extremely generous. She said, "Of course I'll do it." And she's also Annie. She's like HIV, I got that. Hepatitis, I got that. No problem. This should be no problem. But she didn't notice that she was actually on call for the perinatal hotline as well. So then she gets this call, which is a 21-year-old G3P0, 37 and 5 weeks gestation. Mother's had challenges with adherence, and she's viremic on their last check last week of 16,000 copies per ml. Because of that, they're planning to do a C-section, and they wanted to know what Annie would recommend for the infant. So Annie is resourceful. She goes right to the web. And she just Googles HIV kids and comes up with this, which is the national guidelines for management of perinatal transmission prevention. So these are, I mean, for all of you, it actually is a wonderful reference. You can see the line at the bottom. And they provide pretty good guidance for the extremes of risk. So for low risk, which they define as on therapy throughout pregnancy with undetectable virus, recommend kind of 4 to 6 weeks of zidovudine. So I'm not going to talk a lot about that, but the 4-week recommendation is actually new this year. For as long as zidovudine's been around since 2007-06 in the mid-90s, it's been 6 weeks, and that's just because that's the way they did it originally, and not really because people thought there was something essential about those last 2 weeks of zidovudine for low-risk infants. So recognizing that kind of paucity of data throughout a lot of the rest of the world, they've been just given 4 weeks, and that includes both for high and low-risk infants. And so basically because they did it in Europe for decades and they haven't had any bad outcomes, we've now adopted that recommendation in the US to allow 4 or 6 weeks for zidovudine treatment for low-risk infants. Now for high-risk infants, they define basically as the extreme of really no treatment during pregnancy. So someone basically who's recognized during labor to be HIV infected. C-section is recommended generally for an RNA over 1,000 copies. And then the high risk regimen that they propose is the zidovudine plus 3 doses of nevirapine on days 0, 2, and 6. So these are kind of two kind of clear endpoints. But they do have a section on kind of intermediate risk, and these would be for women with kind of so-called suboptimal control or partial treatment histories. And that font is, I suppose, somewhat intentionally small and italicized because it really kind of defers judgment to the clinician, saying extrapolation of findings from the previously discussed NICHD HPTN 040 suggests that combination prophylaxis should be considered, and basically says to consult a specialist. So here's where we are left on handling this infant. So I thought first we would go through HPTN 040 because this trial really is the basis for the current perinatal guidelines, and then talk about kind of shortcomings and what we might do with response to that data for this infant. So HPTN 040 was a study that enrolled high-risk women of that original category. So infants of mothers who had no antiretroviral therapy at all during pregnancy, the exception being getting zidovudine during labor. Women were randomized into 3 different arms. This was a trial that enrolled across the world at multiple international sites. So they got either zidovudine for 6 weeks. These are the infants, I'm sorry. The infants would get zidovudine for 6 weeks. They would get zidovudine for 6 weeks, plus the 3-dose series of nevirapine, which you just saw in the guidelines, at birth, 48 hours after that, and then 96 hours after that. And then the third arm was the so-called 3-drug arm, which was zidovudine plus lamivudine for 2 weeks, plus nelfinavir for 2 weeks. The results of this trial were published in the New England Journal in 2012. So here's the central kind of finding of the trial. So this is a table that summarizes treatment outcomes. If you go down to kind of the middle 2 rows, I guess I have a pointer here. These are, you can look either at the 4 to 6 week or the 3-month data, but the bottom line is here's the zidovudine alone arm, and they had a kind of 3 to 5% transmission postpartum to infants, and that is compared to basically 2% transmission among either of the kind of multiple drug arms for the infants. So their take home from this was that there was added benefit to using multiple drugs for the high-risk infant. And they basically cited that there was a slightly higher risk of neutropenia in the multiple drug arms. So they took this to mean that, well, 2 drugs is just as good in prevention, but has a slightly lower risk of toxicity. So this became the standard of care and the standard of recommendations. But then again, this is Annie, and she's not just going to look at the kind of one bottom line of this paper. She's really going to read it carefully. And then she notices up top, she's like, but wait a minute. I look up top here, and it says infants with in utero infection, they numbered 5 to 6% in all arms. So in the end, you have more infants in this trial that ended up with in utero infection than had intrapartum infection. So it raises the point that, well, maybe we need to think about what the impact is also of this regimen on those with already established infection. So she reads further, and here you can see that highlighted. She reads further, and there's actually a table. So what you would predict, of course, from giving an infant kind of subtherapeutic prophylactic dosing of nevirapine that had already established infection is development of resistance. And they did look at that in the trial. And sure enough, kind of as you would predict, in the zidovudine plus prophylactic nevirapine arm, a full 1/5 of those kids developed significant resistance to NNRTI. So kind of the negative consequence you fear. The numbers were small. They didn't have resistance testing in all of them, and it didn't reach significance. But this is clearly the trend in that which you would predict. We know that infants getting even just single dose, exposed to single dose nevirapine get resistance. So this is not at all surprising. So where does this leave us kind of in the field? I mean, I think clearly there's room for improvement on HPTN 040. It was a trial that was not designed to optimize the outcomes of in utero infants. It was very specifically targeting how do we reduce transmission. It was about prophylaxis. But I think many of us are now thinking, as we kind of move ahead, we really need to think of the in utero kids, and specifically not kind of lump together high risk as one kind of group. Really, what you're looking at in an infant that's born to a high-risk mother is an infant that's either infected or not. And the in utero infected kids are going to have a different optimal management than you are with your strategy to just reduce transmission in the other infants. And I'll just put out there as well that I think many of us want to improve on the 2% transmission rate even in those that remain. And so there's certainly room for improvement even in prophylaxis. Okay, so what would we want to focus on for optimal treatment of the in utero infected infant? Of course, we would want to reduce the accumulation of new resistance mutations, as we just mentioned. But it also raises the question of whether there could be any potential benefit to immediate treatment of this infant. So historically, and in this trial, the way this would happen is these infants would be tested at birth. The results would come back at 1 to 2 weeks of life, and then they would kind of enter kind of adherence counseling with the family, and then the kids would start therapy, ideally kind of within 2 weeks, 4 weeks, 6 weeks of life, depending on when they were recognized. But I think as everyone in this room would recognize, there's definitely a trend towards wanting to treat earlier and more aggressively. And a particular case that I'm sure you've heard of really highlighted this issue for pediatrics. So this is the case of the now called kind of Mississippi infant with kind of results originally published in the New England Journal in 2013. This is an infant that was born to a woman who had no prenatal care. Her rapid test was positive in labor, but she delivered precipitously before she could receive any prophylactic or treatment therapy. Infant was transferred to a different hospital at 30 hours of life, and the providers there wanted to be aggressive. So basically put the kid on what their best guess was for a good treatment regimen at the time of arrival, and also sent testing right then. But they basically put the kid on treatment prior to even getting the results for the testing. But sure enough, the 2 nucleic acid-based tests that were drawn at birth came back positive. And as I said, the kid was started on zidovudine, lamivudine, and nevirapine at 30 hours of life. So what happened with this infant? Basically, rapid decline of plasma RNA over the first 3 weeks of life. You see, basically got undetectable within a month and stayed undetectable for the first 3 months of life. But then, unfortunately, the family was lost to follow-up and returned when the child was just about to turn 2. And the mother reported having stopped giving the infant HIV meds at around 5 months, and the pharmacy records, to the extent that they could ascertain them, kind of backed this up. That it looks like basically it was therapy for 5 months and then stopped. And they were really surprised that when they checked the infant, expecting kind of a low CD4 and high RNA at this level, that there was no plasma viremia. So this case generated a lot of hope. I should say a lot of hope that, wow, this really could have been some sort of early abortive treatment of this infant. There was a lot of debate whether to call it cure, whether to call it remission, but certainly a kind of proof of principle that very early aggressive therapy of this infant could yield potentially kind of good benefits. So the infant was studied, the infant was followed closely, and then unfortunately at age 46 months, so again like almost 18 months or so later, the infant rebounded. So initially with a copy number of 16,000 copies, repeated immediately 10,000 copies. The infant was subsequently put back on therapy and was suppressed quickly. So needless to say, this was a real profound disappointment for a lot of people, particularly in pediatrics, but really in general for those paying attention to kind of cure research and the hope and proof of principle that this infant represented. But but I think many really still consider this a success. This is a long period of time for someone with acute infection to go off therapy and not have any rebound. And consider it still kind of worthy of study and still an important proof of principle that early therapy could lead to kind of lower levels of seeding of reservoirs and better clinical outcomes in these infants. And as I'll talk about, there's still research going on to kind of redo the Mississippi infant, albeit with slightly deflated hopes for a cure necessarily. But I think this case really did change the way we think about management of these high-risk infants. So like I said, it really makes you think that when you have this infant in front of you that's just born, we need to think differently about prophylaxis versus this idea of kind of presumptive treatment of those infants that are in utero infected. So I think I want to pause for a second and talk about difference between prophylaxis and empiric treatment. I think we, often when we're treating, say, someone with pneumonia and we're doing kind of a rule out, we're using treatment level dosing as a kind of rule out. And when we're doing PEP for adults and occupational exposure, using kind of treatment level dosing. But for instance, with kind of bone marrow transplants and such, we may use a lower level dosing. So I think it's important to recognize that at times we use what is truly a therapeutic dose, and at times we use what is not. And a lot of the research for perinatal transmission prevention was done with using subtherapeutic doses of medications that they thought would be toxic. So on the this table basically shows differences in dosing for prophylaxis and treatment for the management of infants, and then with showing the doses that they did for the Mississippi case. So prophylaxis dosing, which is that recommended by the guidelines, is on the left. You can see zidovudine dosing here, and zidovudine is actually the same prophylactic versus treatment. Lamivudine, which is not recommended generally, but in special cases is also the same, but it's nevirapine that is different. So this is a 3-dose series that is designed to give prophylactic serum levels over the first 2 weeks of life, not treatment levels. So if you were to look to the guidelines and say, well, I want to give treatment, you'll find that there is no treatment dose of nevirapine in the guidelines because we don't have the PK data yet. So you would be stuck with this, and there really was no option to treat, per guidelines, an infant on day of life 0 at the time that the Mississippi child was born, or even to this date. And so for the Mississippi case, they did a little funky where they kind of split up this dose and made it Q6, and then they doubled the dose of lamivudine for unclear reasons, and then they went with this dose of 2 mg per kg Q12, which is kind of more than this, but probably not even therapeutic doses. And this is kind of what they came up with. And then at a week of life, they swapped out the nevirapine for lopinavir ritonavir and started that in its place. So they kind of made their best guess and did what they did. This is again just to highlight the prophylactic troughs and peaks for nevirapine are kind of 10 to 30 times lower than we would want for treatment. So a real need for dosing if you want to kind of do best by infants and treat them aggressively. So as I said, the field was kind of inflated by the prospect for a cure, and a trial was set up to basically enroll and treat as aggressively as possible infants with in utero infection. The trial is kind of poised to roll until the case of the infant rebound. Where 54 infants were going to be enrolled. They're all going to have had initiated therapy within the first 48 hours of life, but really ideally as quickly as possible after birth. The treatment dose that is proposed in this trial is 6 mg per kg BID. So you'll see 3 times that was used for the Mississippi infant. And this is based on kind of PK modeling data from nevirapine dosing, what we know about metabolism in newborns, and then adding lopinavir as a 4th agent at 2 weeks of life until the child suppresses. So really trying to be even more aggressive than the Mississippi infant was. then follow-up planned in the original trial was for 2 years of life with the goal to evaluate cessation. And there, with the rebound came through just as this trial was about to kind of go out to sites and begin to enroll. And there was a lot of kind of introspection about whether it should still go forward. Is it ethical to take infants off therapy? Does this trial still have kind of importance? And the consensus was basically that it does, that I think there's still a lot to be learned from the early treatment of these infants. Many of us want to put these infants on treatment, even with the kind of data as it is. And so the PK data that will be generated from the trial on nevirapine dosing will be useful in and of itself. But the trial basically is going forward. And the only real difference is that there's not a kind of designated set criteria for cessation of therapy at 2 years of life, but they're going to kind of reevaluate given the kind of state of the data at that time, both data from adults and data from kids, to decide what would be kind of rational criteria for cessation, if any, or just studying these infants and other related outcomes. So trial is going on. It's primarily going to roll at international sites, but there are also domestic sites that will be included. In parallel to that, however, we're going to be setting up another kind of cohort in the U.S. So this basically is going to be designed really, as I say, in parallel to P115 through the Pediatric Trials Network. Same kind of sampling, same clinical data collection. But the idea is to make this possible for non-trial sites to enroll, because there really are only a handful of sites in the U.S. that are involved in the Pediatric Trials Network. And it's kind of to recognize that really where these cases are not just likely possibly, but even more likely to occur are not at the big academic centers where they have aggressive treatment and aggressive recognition of pregnant women. It's really more likely to be in kind of rural areas. For instance, the case where the Mississippi infant was delivered was actually not a trial site, right? It was kind of in Mississippi where they have a high volume, but they didn't have a site. So the idea here is to enable non-impact sites, both academic and even community, to enroll. We've just gotten a go-ahead on this for funding, and so I kind of quite literally mean contact me if you hear about potential cases, because we'll be leading that from here at UCSF. We'll be working with the hotline to get referrals, but we'll also be working through the CDC and through the Impact Network to kind of get hooked into cases that aren't able to come to impact sites. Okay, so to return to the case, so where does this leave you? I've just told you all this stuff about ongoing trials. How do we handle these cases on the hotline when they come in, and how do you advise providers, kind of given the current state of data? I think when we kind of are going beyond guidelines, and particularly using investigational dosing, I think it's always important to kind of go back and say, look, this is not just a unilateral decision of a physician. This is a discussion that should be had with a provider and with the family, kind of saying, look, here's the current state of the data. Here are the guidelines. Here's what we recommend. We certainly generally recommend treating more aggressively, but I think it's important for providers and families to still have that discussion. And I'd say across the country, there is still some diversity. Some people really feel more comfortable just going back to what the guideline says. They're not comfortable giving anything investigational. But most, I think, are calling us kind of for permission and guidance and being more aggressive and treating more aggressively. So I'd say most do seek to treat. The kind of options that as we've come to call them, are the kind of presumptive treatment rule out, where you basically get testing at birth and treat aggressively, and then go back to the prophylactic dosing as soon as in a few days when you have the results from the birth testing. Or you can do the 040 protocol, treat and then initiate treatment within the first week of life if it comes back positive. And there's really we can't really say that starting at birth is going to be a different outcome than starting at 3 days of life, right, in terms of initiation and clinical outcomes. But I think one of the big risks of doing the delayed one is resistance, right, is giving basically subtherapeutic levels of nevirapine for potentially a week of life really does run the risk of harming your ability to use NRTIs in the future. So Annie's about to call, have this conversation. She gets on the line with the provider, but then they tell her, like, well, actually, it turns out it's more complicated. This mother had perinatally acquired HIV, and she had a lifelong treatment with antiretrovirals. And this infant mother has extensive and kind of complicated drug resistance mutations. She's currently on Truvada, raltegravir, darunavir, and etravirine, and she's failing. She has this long kind of history of treatment with multiple failed regimens. Her genotype shows, kind of multiple mutations. I won't go into them in detail here, but the bottom line is like, wow, you're stuck. You're not excited to be using just nevirapine, zidovudine, and 3-TC. The team is ready. They found some DDI in the closet. They think they're wondering if they should use nelfinavir. They're considering etravirine and raltegravir. They're calling us for advice, like, what would you do in this case? And it's hard, because the question is like, what other options do we have for treatment in this? And you remember I just told you we don't even have nevirapine dosing. And we really just do not have a lot. And you're kind of stuck in what you can recommend. And I think there is across the country, again, a diversity of how people reply to this. The caller, I should add, that call was real. I came in last week. So this is a very real call that we're talking about. And they had kind of polled the providers at their site. And one of the kind of older kind of like pediatric HIV docs was like, look, we met with the pharmacist. We made up an etravirine dose. Basically, they think they know, kind of the target trough in this infant. And they're going to make some sort of like between therapeutic and prophylactic dosing just to see, it's dispersible, so they think they can kind of dose titrate it, and they were thinking of giving it. But I think many of us, and myself included in this, really aren't as comfortable with just kind of going that aggressively without the data. Neonatal pharmacokinetics are really totally different. And with nevirapine, we know that, for instance, the doses are going to be much smaller than we use in older infants. You can't use the same dose you use for a 1-month-old in an infant because the liver metabolism changes really dramatically over the first week of life. So it really is just a very different period of time with drug metabolism. So it has to be on a drug-by-drug basis. It can't just be, the kind of cliche, kids are not little adults. And really, particularly in the 0-day to 30-day of life thing, they really aren't. And a lot of these drugs have reasons to be worried. So raltegravir and you'll see Moraviroc are both under a lot of interest right now, and raltegravir with ongoing study and Moraviroc being considered. And these are particularly with reference to this cure agenda and getting agents that we think would really be protective against the establishment of reservoirs in newborns. But both have significant issues, not just for questions of PK, but both, for instance, have at least the hypothetical potential to displace bilirubin. So a lot of these infants are premature. You're giving them something that's going to lead to hyperbilirubinemia. You're going to give them kernicterus and significant complications that really would be unintended and, again, not captured by this idea of, oh, they're just little, let's make up a dose. So I think it really need to be studied in infants. A lot of the data we get on this comes from kind of one of the workhorse protocols of the network, which is 1026, which basically is opportunistic. It takes pregnant women and it looks at the washout of antiretrovirals in the infants. So we get a glimpse of how they metabolize drug with what they've been kind of given from mothers and how they metabolize it over the first week of life. So that's what the basis for raltegravir was. But for Moraviroc, not a lot of pregnant women are on Moraviroc, so we're going to have to set up probably an independent trial on that, and discussions for that are ongoing. So unfortunately, we're pretty stuck. We have kind of the drugs that are up at top. I'd say just as a slight consolation, it seems that even in infants that are born to mothers with really resistant virus end up developing infection with wild-type virus. And so whether that's kind of a bottleneck at transmission or kind of a fitness kind of phenomenon where the more fit virus grows up is not clear. But I think it still underscores that even in people with what would be expected to be clear nevirapine resistance, we still give nevirapine in the hopes that it's going to have some benefit. Yeah, and I think the other thing to keep in mind is, in this case, it was actually documented resistance. But often what happens is we're faced with, oh, the mother has this treatment history and has, say, archived resistance to these things. And you really don't need to worry about that for perinatal transmission, right? The infant's not going to get what's archived in the mother. The infant's going to get what's in her plasma. So you really, if you're going to be kind of worrying about transmitted resistance, it really needs to be based on kind of genotype within that pregnancy during the time that the infant could have been infected by the virus.
The raltegravir under studying neonates, how many neonates are being studied? How far along is that? What in general, how are those studies done?
So those are, that is, I mean, I don't remember the N, but it's like on the order of dozens. It's not many. That study is ongoing and enrolling right now in the US. And anticipating data from that in the next year, probably by the end of next year.
And are they going to add in dolutegravir, because that's always sort of we rely a lot more on dolutegravir now.
Yeah, I'll talk about dolutegravir in a second. I think it's specifically for the newborn. It's not currently on the table at day of life 0, but a lot of interest in it in rolling down up as close to the newborn period. And I think it's going to be added to the next 1026 version, so that they're going to be data on it and wash out. I think there's a lot of interest in it, and really for the same reasons as raltegravir. Okay, so what about Clarissa? I think lopinavir ritonavir really was a lesson that has given a little caution to people as well about just rolling things down to the newborn period. So it basically was kind of rolled out quickly throughout pediatrics at the time that lopinavir was kind of the mainstay for adults and kids. And they did kind of just what we were talking about, which was extrapolated a dose down by size to the newborn period without actual data in that group. And then a number of case reports came in around the US about toxicity. So cardiac toxicity with AV block, bradycardia, and cardiomyopathy reports, lactic acidosis, renal failure, CNS depression, respiratory complications, and a couple deaths. So this really led to the US backing off, and now it's only recommended in the US for infants at least 2 weeks old and after 42 weeks post-gestational age. And for that's the reason that we didn't use it here. That's the reason they waited till 1 week in there. I'm not really sure about this data. I think a lot of people thought it was related to the vehicle, the kind of polyethylene glycol that was associated with the formulation, not actually from lopinavir. And truth be told, in South Africa and a lot of the world, they're still using it, and they're not having kind of waves of bad outcomes. But I think at least within the U.S., it's not on the table for the first few days of life. Okay, so I just wanted to pause. That's the end of kind of part one, and we're kind of halfway through here. I just want to mention one thing kind of in the news, since you might have seen it, and then we'll move on to talking about young infants. So this basically was just released a couple days ago. That one of the big ongoing pediatric and perinatal transmission trials had a DSMB review and has a kind of an important finding. So basically, this trial is called the PROMISE trial, which stands for Promoting Maternal Infant Survival Everywhere. It is a very large trial, again, international and domestic sites, and it has a really complicated design. But one of the they have part of the design is for countries where full therapy is the standard of care, so all mothers get full HAART. But then they do have another arm of the trial where in countries where that is not the standard, that women were randomized basically to the different WHO options. So to either zidovudine with single-dose nevirapine during labor, and then 2 weeks of tenofovir and FTC after delivery, or combination therapy for the mothers, which was either lopinavir and Truvada, or lopinavir and zidovudine and 3TC. 3,500 women were enrolled and randomized in that part of the arm, in that part of the trial. And they basically found by this preliminary, this kind of scheduled DSMB review, a significant difference in transmission to infants. So in the kind of zidovudine single-dose nevirapine arm, that was 1.8%, and then it was basically about a third of that in the women receiving combination therapy. So lopinavir plus Truvada, lopinavir plus zidovudine, and lamivudine was down to like 0.5%. So I think, so what do we do with that? I think I need to point out that a lot of people have. This is a somewhat controversial trial, because I think a lot of people really push that this is an important trial to do because it's going to inform management of women in resource kind of poor countries and ministries of health that don't have a lot of antiretrovirals at their disposal. But I think on the flip side, I think many, and I might go so far as to say many of us, believe that this is really a kind of questionable utility and even potentially questionable kind of ethics. That we're basically rolling out what we really should have been able to predict is going to be substandard therapy for women and pregnant women in this trial to be getting that therapy. And it's kind of like, duh, like really, of course, combination therapy was going to result in that result. Those arms have now been closed based on these results, but the trial will going on. And the second phase is to randomize some of these women to either stop therapy after delivery versus continue therapy throughout pregnancy as per kind of WHO guideline, kind of B+ option. So I think many of us are even uncomfortable with that, again, being under trial and a lot of money going into the trial. But you should know that that part is at least going on. One finding that I think does raise a little, is important for us to think about is they did find a slightly increased toxicity in the tenofovir versus zidovudine 3TC based arm. I said 3TC, but that should be the zidovudine arm. It had severe adverse pregnancy outcomes. It talks about low birth weight, premature delivery. They really haven't listed the specific data and the numbers around this, but the idea being that the differences in the NRTI backbones might have led to differences in toxicity, I think is something we want to pay attention to with regards to the infant. There is concern about use of tenofovir in pregnant women for its impact on kind of bone development in kids. And tenofovir, while such a mainstay of adult therapy, is still a little uncomfortable in kids with developing bones. So I think that is something we're all going to look forward to the data about and we'll be considering going forward in treatment of infants. But anyway, I'm going to leave it at that, and we'll move on quickly to the next.
Ted, can you just comment, because I think the bone part, that makes sense, and maybe that's associated with the major birth defects, although I didn't look through to see if those are mostly bony, but I was surprised to see the low birth weight, the premature delivery, stillbirth. I mean, I was trying to think in my head when I saw these data, well, what's the mechanism for tenofovir itself being associated, because that's really the only difference that's there. We know that tenofovir levels can be higher with boosted PIs, but that's just not, I thought that was surprising. There was a whole thing out there about just boosted PIs in general being associated with more low birth weight, but they seem to really isolate it to this arm and not.
Yeah, so I think we need to see the kind of when it comes out. I can't think of a reason, kind of pathogenically or kind of a mechanism for tenofovir specifically to induce premature labor. I have to say, like, we really do not understand premature labor in the first place and kind of what prompts it. So I think it's really kind of an important thing really in the global health of this part of the world. I mean, a major portion of HIV infected and uninfected women deliver prematurely in this part of the world in the first place, and I think a lot of work's going on that. But I mean, likewise, I don't understand it, and I don't really understand why tenofovir would be associated with it.
I didn't see them specifically comment on renal toxicity. I mean, that was one thing I was trying to think through. You know, the levels that get high and the moms have a slight bump in their renal function, but I didn't see that commented on. Yeah,
all we have is that one NIH press release at this point. So I think we're just going to have to look to see. I mean, presumably this will be kind of late breaker material for CROI, or it might even be too late for that. But I think we're just going to have to see the data when it comes out. But great points both. Okay, so where does this leave us on prophylaxis? Again, universal therapy is what we should be doing for these women, and what should virtually eliminate infection in infants. I think that's the biggest take-home point. But I think we really need to think of the high-risk infant as a heterogeneous group. We need to improve on 040 and develop treatment dosing for infants. I think practically in this interim, many of us are putting forth this kind of presumptive treatment rule-out as opposed to just taking the kind of high-risk protocol at face value. And I think it's also important to know that over the next kind of 5 years or so, we're going to have a shift in diagnostics that's going to really change this dynamic. Even here at San Francisco General and UC, when we send birth nucleic acid testing, it can take a week to 2 to come back. But if you have that information within a day or two, that really can get you either appropriately on therapy for these infants more quickly or off into the prophylactic therapy, and really will change, I think, a lot of the kind of rule-out logic that we have to do for these infants. And this, I think, is possibly going to be true even in rest of the world as more rapid diagnostics for nucleic acid-based testing for HIV are easier. Okay, so we're going to pause, and I'm going to do a second case, which is a little quicker and kind of simpler, just to highlight kind of current questions in the treatment of infants, actually in children that are a little bit older, outside of infancy, but not yet young adults. So basically, we'll take the case of a 2-year adopted girl who comes to your clinic here in the US with newly diagnosed HIV. And simple question, what's the best first-line therapy for this girl? Again, we turn to our kind of super busy table, and you see that things are pretty good above 3 years, but really below 3 years, I mean, I say 3 months, but that's because between 3 months and 3 years, these are our options. We have lopinavir and fosamprenavir as our only PIs. We have nevirapine and efavirenz, although the dosing for efavirenz is a little uncomfortable in this group. While we're doing kind of question of low dose efavirenz in older kids, we're actually finding a lot of kids get subtherapeutic dosing as standard dosing in this group with a lot of variability in metabolism. So we're less comfortable with efavirenz in this age group these days, and, but we have a handful of NRTIs. So it kind of comes down to kind of nevirapine versus lopinavir are the big options, and then just new data for dolutegravir is going to be coming, but it's actually not here. So I guess that's kind of an area that should be orange and not green. All right, so to step through it here, I won't go through these all too much, but really ongoing studies in preterms, and we have these for the NRTIs. P1070 is going to work on this dosing question and efavirenz that I mentioned. Etravirine is under study down to 2 months of age, but is not enrolling, and that is still generally used in concert for salvage therapy with darunavir and not its primary therapy. And there is a trial opening up for, or I should say, ongoing for rilpivirine, but not certainly not available for this infant in your clinic yet, or this toddler, I should say. So atazanavir, a lot of use of atazanavir in infants. There was a trial in the U.S. that was completed down to 3 years, and so this is now looking in younger age groups. So that could be an option, but again, lopinavir would be the one that people would go to first. And the guidelines really up through this year have said lopinavir would be the first choice for this infant. So what about dolutegravir? So P1093 is enrolling. This was the question that came up earlier. We now have data for dosing down to kind of 6 years of age waiting on dosing for these lower cohorts. This is a PK trial, so it's not going to be about clinical efficacy, but we really need this to get to the younger age groups. And the challenge for enrolling this right now is we have the sites poised to go, but we don't have the formulation. And they're basically trying to make a kind of a granule and a dispersible formulation of dolutegravir to allow more specific weight-based dosing in these smaller age groups. And then I'll talk a bit about the Odyssey trial, which will be starting up soon in a minute. And then we do have raltegravir data down to kind of 4 weeks of age, but a lot of hesitance to use this in younger age groups when we don't have the concerns for adherence, twice daily dosing, et cetera. So this can be considered in that age group. Okay, so one broad comment about pediatric versus adult data. I think we don't have kind of beautiful tables of randomized trials for switch from this to that for a lot of the head-to-head stuff you have in adults, and I think quite reasonably aren't trying to redo them all. We don't have the same populations, and it would be frankly a waste of money. So a lot of the trials are based on really just extrapolating doing pharmacokinetic studies so that we can extrapolate differences in clinical efficacy. But there have been several randomized trials that were set up that really were set to target more questions for therapy relevant to the rest of the world, and that I'll highlight now that have led to some kind of curious results. So one of them is this question of lopinavir versus nevirapine for a child of this age group. This was a trial set up that enrolled infants 2 to 36 months of age. They were randomized to either nevirapine or lopinavir. And the primary outcome was a composite of discontinuation of study drug for any reason or virological failure by week 24. And the first cohort enrolled nevirapine-exposed infants. And I think everybody was really not surprised to see the results from this trial, which showed that there was a 39% failure rate or 40% failure rate of nevirapine compared to 20% for lopinavir. So given the nevirapine exposure, people really weren't surprised. Presumed kind of resistance in these infants led to this. But what really got people's attention was kind of cohort 2, which was the same trial enrolling infants that had not had nevirapine exposure. And they had not just similar in direction, but virtually identical results, which is to say superiority for lopinavir with a lower failure rate compared to nevirapine at exactly the same ratio, and that is without nevirapine resistance. So people have really scratched their head on this about what could be this difference. I mean, was it just that all the people in this cohort weren't telling the truth that they had nevirapine exposure? I mean, I suppose it's possible in some cases, but it's hard to explain why it's exactly the same. But I think a lot of the attention has been on how nevirapine in this group is just challenging to dose, that the lead-in dosing that we do in adults to avoid early drug reactions may not be appropriate for these infants that have higher rates of metabolism, lower rates of toxicity, and when you're starting with someone with kind of multiple millions of copies and putting them on nevirapine, if it takes them 6+ months to get to undetectable, it's going to lead to a higher rate of failure. So there are trials going on now looking at lead-in with just a standard dose, I should say no lead-in dosing for nevirapine, to see if you can make this different. But I think the question is out really, what is the best first-line therapy? Is lopinavir actually that much better based on this? As a bit of a shameless plug, I'll put in some data that we generated from work here at UCSF in Truro. This was a trial where we enrolled 185 infants and randomized them to lopinavir versus NNR-based ART. The primary outcome of this trial was a malaria incidence, but certainly it begged to have secondary analysis, and as was planned in our protocol, of the virologic outcomes in these infants. Median age of our group was older, so was 3 years of age, which was the top of the age limit of 1060, but we found really zero signal of any difference between the arms to the extent that we could. So again, our numbers are small. For ART naive kids, we had basically 65 in each group, but really kind of pretty convincingly similar rates of virologic failure in Kaplan-Meier modeling. So again, I think the question is out whether lopinavir is the best. Even kind of recognizing this data, there's been a kind of a slow rate to roll out lopinavir in Africa, where this is most relevant. A lot of that relates to tolerability, a lot of GI distress in kids, variability in PK, so concerns with that, cost, and I think basically that was the only thing that was on the horizon. But I think a lot of people were not satisfied that it was going to be the salvation for Africa. So I think we then enter basically the period, the era of dolutegravir. And I think a lot of the interest in dolutegravir as moving from a great second line to a great first line regimen is spilling down into pediatrics. As I mentioned, P1093 is going forward to really elucidate the dosing, but as really the kind of only big strategy trial or clinical trial in the development right now in all of pediatrics across the world is one called the Odyssey trial, which has just been put forth. This was put forth by the Pediatric HIV Trials Network called PENTA. It is an open label multi-center trial where they're going to randomize kids to either dolutegravir or, quote, standard of care. They list no bottom age limit, and it's going to go up to 18 years of age. And it's going to be for children that are both starting first-line therapy or switching to second-line ART. So a very kind of ambitious and broad-based study. They plan to enroll 700 kids. And I think, one of the strengths of being this broad is it should help them enroll pretty quickly. It should, in theory, because they can enroll both experienced kids that are failing and as well as naive kids and across these age swaths. But I think a number of us have concerns that this may not answer a lot of the important questions about certain subgroups that remain. So, for instance, in young kids, we know that we don't even have a formulation for kids less than 6 years of age. This is going to start rolling out in the next few months. We're not going to have that dosing for 2 years, and there's no plan to stratify by age. So they're probably going to fill up with older kids and really not have any kids in the younger age group, but probably not enough to, on stratified analysis, answer this question about kids less than 3 years of age, which is really where we think we have the biggest question about what the best therapy is. A mix of background therapies, a mix of the kind of naive and the experienced, I think also lend questions. So I think this will be important. It certainly will probably be one of the landmark trials, but I do not think it's going to really answer some of the more focused questions that we have. Another is the best treatment for kids with TB therapy. They include some PK on that, but I think it really seems probably inadequately powered to answer some of those questions. So in the Pediatric Trials Network and the impact, there's a possibility that we're going to set up a similar trial, but really focusing on specifically the less than 3 age group, where it seems like data will be necessary. But that we will have to see if that develops. So just a few kind of broader comments. I think as we think ahead for older children, what are the kind of longer term questions that we'd like to answer? I think these are kids that are starting therapy, as I just mentioned now, at day 0 of life with potential for lifelong therapy. I think if anyone is going to be suffering long-term toxicity from antiretrovirals, it is these kids. And as I mentioned, the kind of reliance on tenofovir-based regimens we can't do with as much comfort in kids given bone development. So a lot of attention will focus on TAF for its improved side effect profile with hopefully some of the same kind of durability benefits of tenofovir. Gilead is doing these trials kind of on their own, but we will possibly be collaborating with some more kind of strategy-based comparisons within the networks. A lot of interest in kind of novel formulations, so kind of long-acting formulations, kind of depot versions of medications. As anyone who has just either an adolescent at home or an HIV-infected adolescent can imagine, like getting them to take anything or do anything every day as per a rule is a real challenge. And I don't want to make light of it because it really, these kids, with that same kind of immortality complex that teenagers have, it is a real challenge to get these kids to stay on their meds and not develop resistance. So a lot of interest in making it easy for them, where if you could just give a shot once a month and have it do. So we're really looking forward to working with an industry on developing some of those formulations. And then I think going back to think about now that new agents are coming in line and dolutegravir data will be coming out, what is going to be the most rational sequence of treatments for infants growing up, and particularly in Africa, where you're probably not going to have easy resistance testing anytime soon. So I'm gonna stop there, and we're gonna turn with our last 10 minutes to discuss with Clarissa. Clarissa, do you want to join the stage? I think I'll just say a couple words about the epidemiology, but we'll move quickly because our time is a little bit limited. This is the most recent data, just to give you the scope of the epidemic in young adults. This is the kind of most recently released data from the CDC, which is 2012 data that cites the rates of diagnosis of HIV among adults and adolescents. So this is kind of all things told rate of 18.4 per 100,000. If we look specifically to adolescents, now unfortunately, it's really embarrassing. You know I'm not an epidemiologist when I'm doing this, but this is now 2011 data for kids because they haven't released it stratified for young adults yet. But you can see much lower for the 13 to 19-year-old age group, so from 18 down to 7.6. But if you look at the 20 to 24-year-olds, it's 36.3, so basically twice the overall rate in the young adults. And 20 to 24-year-olds, that is our clinic. Basically, young gay men that are coming to San Francisco are becoming infected. And it's a really important part of the epidemic, I think, both epidemiology and also to recognize the differences that it takes to take care of this population. So one last slide. This basically just shows that the rates are, as everybody knows, not going down, but rising in this age group over the past decade. And a lot of differences epidemiologically about this group. African American young men are disproportionately represented. Among this group, it is primarily from male-to-male sexual contact that these young men get infected, but from heterosexual contact among young women. So, sorry for the kind of rapid fire on the epidemiology, but really our goal was to just set the stage that this is an important group nationally. This is an important group that we take care of here in San Francisco. And Clarissa will be taking over the mic now to tell you a little bit about what we do here.
Okay, so I have 5 minutes, my rapid fire.
Yeah, rapid fire, 5 minutes.
So I basically wanted to talk about, and this will be brief, about what we're doing for our youth and address this high-risk population and their needs in our clinic. And one thing we try to do, and again, no money, but just a lot of desire and passion between the clinicians who have a desire to work with this young population, is we try to co-locate our youth on Wednesday afternoons. And one of the things I found when I started working with young people, there are a lot of challenges for them coming to an adult clinic. And too many to kind of list right now, but one of the biggest challenges I found was they just found our environment horrifying. They would come into the waiting room, and some of them would literally just leave, freaking out that, you know, they didn't see anybody their age in the waiting room. They saw these people, and some looked fairly ill, and this really, they thought, am I going to die? Is this going to be me? And so it was really frightening for them. And so I decided, well, let's get the providers who want to work with kids. I call them kids, they're 20 years old, but, and co-locate them so that they actually see other people that are like themselves, and they see providers who are youth-friendly. Because communicating with young people is a little bit different. They don't do phone very well. They do text really well, or email. They also, even though many of our kids are behaviorally infected, so different than the perinatal group that Ted primarily takes care of in his other practice. So they're very different populations. And although these youth can survive on the streets, what I realized is they didn't know how to get a refill at a pharmacy. And we have, so we also decided to do something to educate these youth, because these are high-risk youth, probably not taking their, many of them not taking their medications and maintaining their viral load below level of detection, and probably having a lot of high-risk sex. And interestingly enough, they all have these networks. So a lot of them run in these networks, and I may know person A, but not see the 20 other people they're associated with, but some of them may be infected, may need to be tested, may need to get in care. So my idea was like, well, if I educate one person, then maybe they'll tell 2 friends, and they'll tell 2 friends. And so we tried to figure a way to how to reach our youth in terms of education, to improve their knowledge around HIV and improve their adherence. And so in 2011, we got a small little Hearts grant from San Francisco General Foundation, and we put together a youth group, which we thought in the beginning we're going to be very structured, and Catherine and Oliver, we're going to have this educational program. And what ended up happening was that it's a little bit more loose. The youth are really interested in learning, and they pick their topics, and it's actually become more of a support group for them in many ways. They're there with their peers. This is predominantly a group of youth of color, which is very interesting, and they're very open. We've had discussions around stigma. We had Austin Nation, who's fabulous, and came and led a discussion around disclosure. Last week we had Hyman Scott talk about PrEP and PEP. And it was really good, because a lot of the youth talk about how they take this back within their circles and educate their friends about, oh, by the way, you know, you should get on PrEP, or maybe, you know, you need PEP. And I was really impressed by one of our youth who commented that since he started coming to group, he was able to learn more about his disease and be in more control. His adherence has improved. And that's really impressive to me, that they're taking more control. These are people who are going to be taking meds for the next 40, 50 years. And so trying to give them the tools to really be empowered to take care of themselves is really important. A shameless plug as well for some of the youth organizations that I'm involved with. Bay Area Young Positives, that is an organization that provides peer support in a safe space for youth from the ages of 13 to 26, and Larkin Street Youth Services, and the fabulous Adam is here, the nurse down at Larkin Street, who I have a very close relationship with, because I do a transition clinic down there. One of the other problems with Larkin Street, they provide wraparound services, medical, mental health, housing, up until the age of 25. At 25, these youth need to go out into the adult world, and this became a big problem in that they no longer had housing, they no longer had food, they no longer had medical care. So what we've done, Adam and I, is we have a transitional clinic where at age 24, because at 25 it all is gone, we try to role model how healthcare would be an adult clinic and try and transition their care up to Ward 86 or other clinics, whichever is appropriate, and teach them how to get their refills, how to go to the pharmacy. So these things that for many of us are just, no-brainer, so to speak, we really have to teach the youth how to do these things. And I think both the youth group has been really well attended. People come pretty religiously month to month. And our little seed money is the pizza money. And I think the transition clinic at Larkin Street has been really successful, and it's been really great working with Adam and just trying to capture these youth who unfortunately are struggling with a lot of addiction and mental health issues. So even if they fall off the map, we do know them. I now know them. So when I get called by PES and there's a youth there who transitioned out, I know who that is, and we can try and engage them in care. So these are some of the things that we're just trying to do for, I think, a population that is going to be in care for many, many years to come.